Hello, this is Jenna Quinn, CEO and founder of Perfecting Peds. Perfecting Peds is the first of its kind in the United States. We, as pediatric pharmacists, provide what's called comprehensive medication management to all medically complex pediatric patients. Our goal with Pediatrics in Review is to review, analyze, and gain knowledge on the most up-to-date literature so we can service our pediatric patients as best as possible. Thank you for listening.
You're listening to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Thank you so much for joining us. This is Pediatrics in the Review via the Pharmacy Podcast Network. I am super excited about our guest today, Claudia Fox, who is an expert in childhood obesity, which I feel like, if anything, now post-COVID has been an exponential problem as compared to the later, and practicing in the hospitals, seeing how profoundly the obese pediatric patients were even just affected by COVID compared to the other population. It was a true testimony that, this warrants a lot more attention. When I saw her and her whole team and subcommittee publish these new guidelines on pediatric obesity, I was super excited to have us on. Dr. Fox, first things first, can you just give us a little bit about where you're practicing and what your day-to-day looks like?
For sure. So thanks so much, Jenna, for having me join you today. I'm really excited to speak with you and your guests. I am a pediatric obesity medicine specialist, and my clinical work is here at the University of Minnesota in our pediatric weight management clinic. So we are a multidisciplinary program that treats children and adolescents who present to us with usually fairly complicated, severe obesity.
Thank you so much. And like I said, I feel like which we'll talk about, we have to get away from the stigma and view it just similar to mental health, just view it as a disease state that needs to be treated just like everything else. It's not the blame game of, it's their parents' fault or yada, yada, yada. Just like mental health, which is near and dear to my heart, I think it's a disease state, and just like anything else, it has to be managed. And we have to come from a very non-judgmental place when talking to patients about this.
Yeah, I think if nothing else, if that could be the nugget that you all take from this podcast, that would be it. That obesity is indeed a disease. It's not the kid's fault. It's not the parents' fault. This is a disorder of energy regulation at its core. So it's biologically based, certainly influenced by our environment. But we all live in this environment, and yet not everybody has obesity. So it is those who have the disorder of energy regulation who go on to develop obesity. And so it's not under anybody's control. We don't have volitional control over our body weight any more than we have volitional control over our body temperature or, breathing or any other physiological process that's supposed to be highly regulated. That's out of our control. It happens automatically without us thinking about it. So, when parents present and are concerned that, maybe they're not feeding their children right, or their children aren't getting enough exercise, well, that might be really a symptom of obesity rather than the cause of obesity. And so recognizing, stepping back that, okay, yes, obesity has really specific pathophysiology, and that's what we're targeting when we're talking about treatment.
That's awesome. Thank you so much. And yeah, I think it's a whole culture shift that I think we're getting better at. I'm a little bit.
Slowly, tiny bit.
Tiny bit. I'm a big advocate for mental health with my own anxiety, postpartum, OCD. I mean, it's scary. And so a lot of things aren't, in your control in the way that, you can work your best at it every day, but what it comes down to is it is like anything else, just a disease state. And so you have to manage it. So first things first, just to step back for 1 second, obviously you guys established these amazing guidelines. And to be honest, like this is what I could find the first robust data expert panel that I've ever seen. Is that true?
Yes, so this is you're talking about the American Academy of Pediatrics clinical practice guidelines around the assessment and management of obesity. I was not part of the writing committee, to be clear.
Okay.
I am an executive committee member of the section on obesity for the AAP, but I was not a participant in the writing. So just to put that out there. But yes, you are right. This is the first guidelines that were based on evidence. So the recommendations that are published in these guidelines are based on clinical trial data, hardcore facts. In contrast to previous recommendations that were supported by the AAP, which were simply that they were expert recommendations based on what knowledge we had at that time, which that was back in 2007, which at that time we didn't have all the robust data that we do now. Yeah. So that's an important distinction that yes, these are clinical practice guidelines based on current research evidence.
Awesome. Thank you so much. And just for those, I'm sure most people listening, but we do get some parents listening as well. So I want to just make sure it's comprehensive. How do you define overweight and versus obesity?
Sure. So, obesity is defined by its manifestation of excess body fat mass. So that's what we're talking about. When we talk about obesity, it's a state of having excess body fat mass. And so how do we then measure, what's the best way to measure body fat mass on a person? That's really hard to do in the clinic. The best way to do it is to put somebody on a DEXA scanner, for example, where you can actually look at their body composition, but that's not practical. So we approximate a person's body fat mass using the BMI, body mass index. And by definition, obesity is having a BMI greater than the 95th percentile for age and sex for a kid. Overweight is having a BMI between the 85th and 95th percentile for age and sex. There's a lot of concern out there, I think, amongst the lay public in particular about the utility of BMI and how robust is it in terms of diagnosing a person with obesity. It is not perfect, for sure. There is a possibility of either over-diagnosing or under-diagnosing a kid with obesity. So it is not perfect. So for that reason, it's important that if you are a parent of a child who carries extra weight, that you talk with your pediatrician about the finding on their growth chart. Does it seem like the BMI really is indeed identifying high body fat mass? For the most part, the majority of the times it is. It is a fairly, it is an accurate reflection. It's very rarely would we say that person has a high BMI, but it's not related to excess adiposity.
Okay. Very, very good. Thank you so much. And then I know we alluded to this in the beginning, but what is the prevalence, of obesity in the US, and how has it been affected by COVID?
Yeah, so back in the 1960s, only about 5% of kids in the US had obesity. Today, it's nearly 20%.
Wow.
So prevalence rates have increased dramatically, and then COVID came and things got even worse. So during COVID, there was a doubling
Wow, I believe
the
it.
rate of BMI increase. Just over those few years, and we all lived through it and are not surprised, right? We were all sort of stuck inside, immobile, eating a lot, very stressed.
Yeah.
So
it was sad too, just to see, like, I felt like for me, what really hit home and what was sad was I would see a lot of these obese patients come in, and they got COVID and they were as young as like 10 and 12, and their body, in addition to COVID, it activated a type or a diabetes, whether that's type 1 or type 2. And I saw some pass away, and it really messed me up. It was just like, and so I know this isn't where the direction we're going, but when I had an opportunity to enroll my kids in the COVID vaccine trial, I did it right away. And my husband was like, why? And I'm like, because no, not all the kids are getting sick, but seeing how these obese kids get, for some reason their body activates the diabetes because of the virus. And then I've seen how fatal, a couple of them died, and it just hit home, and it was really sad to see.
Yeah, well, you're right. So children with obesity did fare worse when infected with COVID. So that for sure, obesity is a risk factor for worse outcomes from COVID. And we also saw, sort of to your point about sort of a blip up in rates of diabetes during the pandemic as well.
Yeah, it was very anecdotal, but I'm like, I think this must be happening around.
It was. Mm-hmm, mm-hmm.
And then I know we touched on the stigma, but really, who is at most risk of obesity? We talk about the social determinants of health, so I'll let you take it away, but it was very interesting reading the guidelines.
Well, so, it's important to recognize that the greatest determinant of a person's shape or size or their BMI is their genetics.
Yes.
40 to 70% of the variability in BMI is related to genetics. So, again, to harken back to, this is sort of baked into your DNA. You can't help it if you have it. You can't help it if you're slender. You can't help it if you were born with brown eyes or blue eyes. And this is part of the package that you've inherited from your parents. So that is the most potent predictor of developing obesity. For sure, there are a lot of other factors. We think about sort of the biological factors. There are psychological factors and then social factors. So among the biological factors, for sure, genetics, polygenics. There are very rarely monogenic forms of obesity where there are single gene mutations along the leptin-melanocortin pathway, which is the pathway by which our bodies are supposed to regulate hunger and fullness, hunger and satiety. So monogenic obesity is something that we see particularly in specialty care clinics, where these kids typically present with early onset severe obesity with hyperphagia. Other biological contributors might include stress. It might include obesogenic medications. It might include endocrinopathies, though even that endocrinopathies are exceedingly rare, accounting for less than 1% of obesity. So even though many patients might think, oh, my kid must have Cushing's because they have a buffalo hump, or they must have hypothyroidism, it's a very uncommon cause of obesity in children and adolescents. So those are biological factors.
Yeah.
There are psychological factors that predict or contribute to obesity, to mental illness, stress, anxiety, depression, binge eating disorder, where we see a lot of ADHD is a common comorbidity with obesity, and then all of the social factors that you are all well aware of: food insecurity, stress, school food, lunch, food, or lack thereof. So,
Yeah, in the summertime, you always think of the kids that don't have that you take for granted a lot of times.
Yeah. So really, when we think about those that are at highest risk for obesity, are those who have a familial predisposition, who then may additionally have some of these other exposures, whether it's some mental illness, psychosocial stressors. Those are the kids who are at greatest risk.
Wow. Okay. Thank you so much. And now this was interesting to me. Just reading how extensive, which makes sense. The more you touch base, the more therapy that you're doing with the families, for lack of a better word. That's what it is.
Sure.
What is, comprehensive obesity treatment? And the first thing that comes to my mind is I know this is well founded in the adult population, but how can we use remote patient monitoring to really help touch point these patients more? Again, I would love your opinion of all the above.
Yeah. So comprehensive obesity treatment involves treating the child as a whole person, not just treating the number on their scale. So like I just indicated, obesity has lots of contributors to it, whether it is depression or poor sleep or some psychosocial distress. Comprehensive obesity treatment involves addressing all those factors that may influence a child's overall well-being, which in turn automatically influences their weight status. So that is best exemplified by a multidisciplinary approach, if you can have that. So a pediatrician who is capable of addressing and identifying mental illness, of identifying weight-related comorbidities that may be contributing to excess adiposity, like diabetes or prediabetes. A pediatrician or physician or healthcare practitioner, somebody who's competent and capable of identifying all of the weight-related comorbidities, and then maybe having somebody, whether it's a social worker, if you don't have the ability to do it, to help support some of those social determinants of health that may be impeding health in a general sense. So that it's comprehensive obesity treatment is usually chronic in nature. That is, we don't usually think of it as, you attend these 5 sessions and then your obesity is cured. No, rather it is chronic. It involves chronic care. So with frequent touch points, checking in with the family and the patient around how they're doing, what's going well, what's not going well, and iterative, like how do you modify the treatment over time to meet the needs of the family?
Yeah, and I'm sure, just from toddler to then childhood to then I think of like adolescence, like how wildly different even like my personality was.
For sure, for sure. And I have kids now that are in their early 20s that I've been seeing since they were 13, 14. And, so it's a obesity is a chronic disease. You don't grow out of it, you don't cure it, you manage it like any other chronic disease, like
Yes.
diabetes, like asthma, just like that.
Yeah, I think that's a really awesome takeaway. So, I mean, we alluded to it, but what other additional comorbidities come with obesity? And really, that's obviously a huge reason why we want to manage it as well, is because we want to make sure all the various comorbidities that can come with it are minimized.
Absolutely. Absolutely. So obesity affects pretty much every single organ system. So there's an opportunity, if you will, for lots of problems to arise. The ones that are most common include non-alcoholic fatty liver disease, pre-diabetes, though, the rates of type 2 diabetes are increasing dramatically as well, but we see still pre-diabetes is more common. Hypertension or dyslipidemia, those are both very common. Mental illness is also exceedingly common. Depression, anxiety, PCOS is also one that is seen relatively often. So many organ systems can be involved, including musculoskeletal system, neurologic system, such as with idiopathic intracranial hypertension. So really, it appropriate treatment would involve assessing for all of the potential complications.
Yeah.
And then addressing them.
Yeah. I didn't even know that the intracranial pressure, it's even down to that. That was really interesting. Reading the guidelines. I was not aware of that.
Yeah. In fact, our youngest patient who had bariatric surgery was a 12-year-old boy who had severe intracranial hypertension and was at risk of losing his sight. So that's why he had surgery, and it was for sure sight saving for him.
Wow.
Mm-hmm.
Wow. So this is also interesting to me, and I would love, as a parent, I was trying to gauge what is my feeding style, because that was really interesting too to think of. It's not something that you as a parent really stop and pull back and evaluate. It's kind of like, just like you're saying, like genetic, like how your parents fed you was kind of like how you feed your kids, and you don't even think about it. Like I'm guilty of, like, once a week we do McDonald's. And so, that was what we did as a kid, and I don't even think about it. And, I have a very, I just put food in front of my kids. If they eat it, great. If not, okay, I'm going to offer you the same thing a couple hours later when you're hungry. And you don't even think about, is that the right thing to do, or is that the wrong thing to do? So yeah, I would just love for you to elaborate on that too, because again, it's not something that I even have reflected on in my 6 years of parenting.
Right. So there is an association between certain feeding styles and childhood obesity, but remember, it's an association, not a causation, right? So kind of to your point, like, is this nature or nurture? Is the feeding style related to what you as a mom have inherited from your own parents, as well as any sort of formative experiences that you've got from your own childhood? So I think we need to just be cautious about the the causality of different parenting styles and childhood obesity. Having said that, there is an association between having an authoritarian parenting style and having children who carry extra weight. So authoritarian is a parenting style that is characterized as being very firm, inflexible, my way or the highway kind of an approach. So like you have to have this, you can only have this, and you have to eat all of this before you can leave the table. In contrast, authoritative is one that supports limits, but those limits might be arrived at mutually between the parent and the child. Like, okay, you can have some dessert today, but it's going to be either this healthy dessert or that healthy dessert. So there are limits, but it's a more collaborative approach. And so, for whatever that's worth, that sort of more collaborative, warm approach, discussing why there are such limits, if you will, tends to portend better outcomes.
Got it. Yeah, because I'm pretty, I wouldn't say lenient, because I definitely have rules, but it was just interesting to watch because like I don't even realize that I do it, but I do always give them options because I want them to feel empowered at all times.
Exactly. So that is a key feature of authoritative parenting style.
I mean, like, you're giving them two good choices, but they have no idea. They're like, yeah, sure. Okay. Broccoli or string beans. Okay, great. Let's do that. Yeah, I found that because I'm very inflexible, a perfectionist, I have OCD. And so that was like my biggest lesson in parenting was that like I cannot be completely inflexible because it trickles into so many other things that are not good for my child. But it's a hard self-reflection. So now we're getting into like the things that I'm really excited about because I'm a pharmacist, so this is very new. This whole approach and kind of and these innovative meds to treat. Again, like we're saying, it's a disease state like any other. So I'm really excited to see that, medication use, like with mental illness, hypertension, diabetes, it's becoming more acceptable. And so can you speak to, what are the medication options and when in your practice do you find it appropriate to, go to the medication versus lifestyle modifications?
So it has been such a, I'll just say that right now in these last, 6 to 12 months, the landscape of anti-obesity pharmacotherapy has just been transforming right before our eyes, even as recently as this week with publications around these triagonists leading to 25% weight loss. I mean, so really, really amazing outcomes. So we are at the doorsteps of a new frontier in obesity management. And that door is certainly wide open for adults. And it is just now, slowly peeking open for the pediatric population. And I would argue, though, that we really need to be starting to get more aggressive and intensive about treatment of pediatric obesity. And I'm not talking about the 9-year-old who might be weighing 70 pounds. I'm talking about the 9-year-old who might be weighing 180 pounds. Like, these are really severely affected kids who definitely need biological treatment to address their biological disease, right? So right now, there are 6 FDA-approved anti-obesity medications for the treatment of children and adolescents. So we have phentermine, which is FDA-approved for, I call them kids, but older than 16 for short-term use. Semaglutide.
Not to interrupt, that's like the old school fen that everyone used to hear.
No, so fen was a combination of phentermine and fenfluramine.
Okay, thank you.
Fenfluramine is associated with heart disease, valvular heart disease, pulmonary hypertension. You can no longer get fen because of the fenfluramine, but phentermine monotherapy is the most widely prescribed anti-obesity medication in the country.
Got it.
Very safe, widely used, quite effective.
Okay, because that's
approved for kids older than 16.
Awesome, because I had to look that up because I was not sure at first. I'm like, oh my, how is this fen back in when? I mean,
yes.
He was like a teenager or something. I'm like, aren't you not supposed to use that? So yes, I had to educate myself. So thank you.
I'm glad you brought that up. So phentermine and topiramate combination therapy, also known as Qsymia, liraglutide, 3 milligrams, which is called Saxenda, semaglutide, 2.4 milligrams, which is also called Wegovy, orlistat. And then the 6th one is setmelanotide. So this is a unique medication. I put it in its own little separate category because it treats only certain forms of monogenic obesity and has also been approved for BBS, Bardet-Biedl syndrome.
Okay.
So that really only covers a very, very small population. But the other 5 ones are appropriate for kids with a BMI greater than the 95th percentile.
Okay.
So class 1 obesity, if you will. Doesn't matter if you have a weight-related comorbidity or not. For the clinician, how do you decide when to start an AOM or not? It's really a conversation between you and the family. It depends on the severity of the obesity, depends on, are there any weight-related comorbidities? What's the family's experience with medications in the past? And educate them. Know that for particularly adolescents with severe obesity, lifestyle therapy is just not going to cut it.
No.
It's a very, very small minority of kids, less than 10% for sure, who will achieve clinically significant BMI reduction with lifestyle therapy alone. So virtually every adolescent with severe obesity for sure needs pharmacotherapy. And I would offer it, we do offer it upon diagnosis, like right when we see the kid. And in fact, that is one of the key points of the clinical practice guidelines, that we as clinicians should no longer be waiting to see how a kid does. We should be offering the full spectrum of anti-obesity therapies upon diagnosis of obesity. So we shouldn't be waiting around trying lifestyle therapy year after year after year, watching BMI increase, and then to suddenly decide, oh yeah, maybe we should use pharmacotherapy or refer to bariatric surgery. No, at diagnosis, we should be intervening.
That's awesome. I mean, I compare it to like ADHD, whereas like parents think they're doing their kids a disservice starting them on meds. And I'm like, no, we have literature to say your child is literally going to thrive via confidence in life. Later in life, they're going to have less chance of having substance abuse. So I think, really when I work with parents, it's like kind of rewiring ourselves that, okay, yes, less is more. I'm all about taking off meds that aren't working. But in those cases where we have a diagnosis and the child's struggling, I'm all about, treating that. And so I think it's a really well needed culture shift. Now, as a pharmacist going through all this is all new to us too. So, you went through the different medications, and obviously they're all different dosage forms.
Sure.
Too. So how do you select one versus the other when you're working with a parent? As a pharmacist, I would love your expertise on that.
Right. So in an ideal world, we would be basing it on patient symptomatology, access to medicine, however, becomes the driving factor. Is it covered by their insurance? Is it even available, for that matter? So right now with Wegovy, there's a shortage of the starting doses. So we haven't been able to start it for the last 2 or 3 weeks. And that's a national shortage. So the reality is that is it covered by the patient's insurance becomes the number one deciding factor. The GLP-1 receptor agonists are very expensive, $1,000 a month, $1,300 a month, depending on what you're getting. And so that's just, cost prohibitive to pay out of pocket. Our center is very active in terms of lobbying our legislator to improve coverage of anti-obesity medications on Medicaid pharmacies. So we've been able to get MA from Minnesota to cover AOM now, which is a huge win. There are only like 8 states across the country.
Let me tell you about Minnesota. I'm from New Jersey, and my company we're all getting licensed in Minnesota because they actually allow pharmacists to practice. I mean, I just applaud Minnesota in so many ways, how innovative they are. And coming from a state that's so restrictive in so many ways, it's like almost like we're living in a different country. And it's like, I'm like, what is happening? So, I started my business here in New Jersey. And when I saw like, wow, we're recognized as providers, we're allowed to help physicians out there. We don't need to even do it through a collaborative practice. But the reason I'm saying this is just because I love Minnesota. You guys are.
I do too.
So that's my sidebar. Just
okay.
We should all live like the people in Minnesota.
Right. Well, we had a sympathetic congressperson, and it only took that one congressperson to really help push our story and push our agenda, and it worked. It's not perfect for sure. There are still some crazy limitations, but it is pretty decent, I must say.
That's awesome.
Like, how do you choose? Whatever is available on the patient's formulary. Do they have any contraindications? So, for example, if a kid has really severe hypertension, I'm probably going to stay away from phentermine or phentermine topiramate, though sometimes we do still use it, making sure that their blood pressure is first controlled. If they have prediabetes or diabetes, I might choose a GLP-1 RA.
I just saw too the release of, this is what I was, Jardiance.
Mm-hmm.
Did you see that? They for the approval for children 10 years and older now.
Oh, for type 2 diabetes?
Yeah. That's what I was looking up. I knew that was like a new thing on the market. So I wanted to
yes. So an SGLT2 inhibitor. Yep. Mm-hmm.
And then obviously, I think about a lot of people when you're talking about sub-Q injections get really, panicked with that. Do you guys offer, and I don't know, like we always did those encephalons in the hospital. I don't even know if they're reasonable outpatient, but I imagine it's a huge source of anxiety for some people.
It's a huge source of anxiety until you show the patients how small the needles are. I mean, they're 4 millimeter needles. They're like the size of your eyelash. So critical for helping getting your patient on board is to show them the pens, show them the needles, have them manipulate them, do a practice injection in the clinic before they leave. It is a very, very seldom patient who doesn't want to take the medication because of fear of needles, I will say.
Awesome.
That's very surprising. I was like, there's nobody going to want to do injections, but I am so wrong on that. That is not at all the barrier at all. More often the barrier is GI side effects.
Okay. So, and the nausea and vomiting, do people...
And got some diarrhea too. Mm-hmm.
Okay. All right. Yeah, no, that's great too. And I mean, when I think of course, you're saying access, and like that's unfortunately like with ADHD, one of the disease states I treat all the time. It's like, well, what's covered? So let's start there, which is not the right thing, but unfortunately the reality. So you think what's there, and then of course, you know, clinical pearls wise, what would be a reason why I don't use this medication? Like reading, you know, just topiramate has that cognitive impairment that sometimes is super real to people. And so I can imagine that would be one. But one question, and I didn't put this on there, but I take care of a lot of children who need antipsychotics, right? Like it is not debatable. Like these patients cannot function if they don't have their atypical antipsychotics on board, which for those listening, if you aren't aware, cause a slew of metabolic syndromes, which include obesity, increase in prolactin, which ganomastia, their lipid profiles increase. And so, you know, with these patients that need to stay on these antipsychotics, I would love selfishly, you know, how do you manage that? Do you do that in partnership with a medication, an anti-obesity medication? And do you have one that you like that works better? I mean, I haven't done a drug-drug interaction check, but that's always, you know, something with the antipsychotics. So again, I would love your expertise on that.
Sure. That is, so we see a fair number of kids who do have weight gain from atypical antipsychotic use. And there is pretty good literature to support the use of metformin for mitigating weight gain associated with atypical antipsychotics, for sure in the pediatric population and the adult. There also in the adult population, there is literature to support topiramate, can also be helpful for mitigating weight gain associated with atypical antipsychotics. So I generally will use one or both of those. Okay. And then I'm not aware of any research that has looked at the GLP-1 receptor agonists as being helpful, but I don't see a reason why they would not be helpful, like for any other type of obesity. Okay. So if that was available to you, that's the one that I would probably even start with.
Okay. Yeah. And reading, it looks like, you know, we have the literature for metformin, but without the atypical antipsychotic, metformin didn't look like it had robust outcomes, you know, just as an anti-obesity med.
No. So metformin alone results in about a 3% BMI reduction, whereas Qsymia or phentermine topiramate is 9%. Yeah. Wegovy or semaglutide is more like 16, almost 17% BMI reduction. So metformin monotherapy is really pales in comparison to some of the newer generation anti-obesity medications.
And the only thing that you're seeing as far as, you know, like you're saying, the reason why you wouldn't do it is really if the GI side effects are so intolerable. But I would imagine, like a lot of other meds, if you can kind of get them to work through that initial period, or, I don't know, like, I mean, again, I'm not as well versed in the peptide medications, but is it like, could you do maybe every other day and then build up? Like, I think about all the other meds where I'm like, well, let's just have that dose for a couple weeks, get that nausea, GI symptoms all at bay, and then increase it again. And that should negate you feeling so nauseous or vomiting or diarrhea. Can you do that with them?
So they all have recommended titration schedules so as to minimize GI side effects already.
Okay, cool.
So, for example, liraglutide or Saxenda is a daily injection. That's the dose is increased once a week.
Okay.
And then Wegovy's is increased every 4 weeks.
Okay.
And so you can always just stay at a given dose and not increase it to allow for the patient to get used to it before increasing the dose. And some practitioners do that automatically. I tend to just go according to the package insert and do the recommended titration schedule.
Okay. Thank you. Because this is all so new to me. I was really excited to have you on because selfishly I'm like, oh my God, I'm going to learn so much.
Yeah. And we also use a lot of anti-nausea medication too to help with for symptom relief, especially in the beginning.
Okay. All right.
Kids really struggling. Mm-hmm.
Just Zofran, or do you guys have? Okay. All right. Yeah. I didn't know if there was another agent. And then the last question is, just very briefly, because obviously a lot of this I wanted to focus more on meds, but when does bariatric surgery come into play? And of course, in adults alone, they have huge success. So I just wanted to just touch on that as well.
Yeah. So for adolescents, the outcomes of bariatric surgery rival that of adults. So not as good as in adults. So there's that. In terms of indications, it depends on the BMI and the presence of comorbidities. Okay. So for children and adolescents, it's a BMI in the class 2 obesity range. So that is a BMI between 35 and 40 or greater than 1.2 times the 95th percentile.
Okay.
So 1.4 times the 95th percentile. And that if you have that lower degree of obesity, you have to have a weight-related comorbidity with it.
Okay.
Or BMI greater than 40 or greater than 1.4 times the 95th percentile without necessarily having a weight-related comorbidity.
Okay, cool. And I guess so I know we kind of alluded to this, but as a healthcare provider, to wrap up, what's your one piece of advice? I might have stolen it in the beginning, but just your one nugget for us.
Well, I would say obesity is a chronic, multifactorial, biologically based disease. It needs to be treated as such. And I think it is incredibly important to educate our patients, their families, and healthcare practitioners about that so that we can reduce stigma and blame and shame and get people the treatment they need.
That's awesome. Thank you so much. Yeah, I know that this is tied to a lot of mental health, and so that's near and dear to my heart. And so I think it's a really great, much needed approach. And thank you to you and all your colleagues who published that. I know you didn't write them, but your expertise for medications was well appreciated. I learned a ton from you. Again, this is new landscape for us all. Mm-hmm. So thank you so much, Dr. Fox, for being on, and I appreciate your time.
My pleasure. Thank you.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.